I do want to talk about walking as medicine. This, I agree, is a critical area that I still think needs a much harder hitting requirement. Doctors tell patients to walk, 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 but very few patients have access to, as in the Netherlands, to a supervised exercise therapy program. And I don't see that ever changing because there aren't even enough cardiac rehab programs to go around. Even for my dad, it took him 3 months to even get on a waiting list to get into an exercise therapy program in our program. So, not even that. I mean, these patients aren't even getting any direction at all in terms of even how to walk effectively to grow their collateral vessels, to reroute that blood flow around any sort of blockages. So I want to talk about the guidelines because when I was reading them, they mentioned that yes, supervised exercise therapy is the holy grail. And it's only the holy grail, though, for a short amount of time. I mean, how many patients actually continue with what they learned in those 3 months and with the regimen that they performed in those 3 months? Because most, especially in the low income communities, don't have their own treadmills, especially at home. And some patients say it's a lot easier for them to walk on a treadmill than it is, on the ground. So they're just not going to continue with that therapy. So the next best is really a structured program, and especially ones that are community-based or home-based. And the reason I really bring this up and I'm emphasizing this is because we have a structured program through the Global P.A.D. Association. And a doctor just last week asked if it was actually an approved structured exercise therapy program. Do the guidelines offer any parameters for that other than the fact that a patient needs to have 3 months of documented exercise therapy, whether it's structured or supervised?
Yes. So great points. I love every point you made. They're right on. They're all very correct and very right on. So number one is that supervised exercise therapy for PAD, even though now it's reimbursed, I mean, at least by Medicare and by some of the third-party payers, which is, by the way, it took us decades to get it to that point, is only for 3 months. And we know anything that you do for 3 months only lasts for 3 months, maybe 4 months. And if you stop doing it, it's like diet. If you diet for 3 months and then you don't do it, you're going to rebound, right? I mean, you need to do, these are things, habits that we need to carry on for life. You cannot exercise for 3 months and be like, okay, great, I'm done. I'm now good. My arteries are perfect. It doesn't unfortunately work like that. So that's one of my pet peeves, to be honest with you, because these programs, while they work while you're doing it. So going back to your point, we need to have a sustainable programs that patients can engage with for life, for years and for life. So that's at least a challenge that you brought up, and I think you're right on. The second thing is that it's not easy to find them. And as you said, many areas in the United States do not have it. And even the ones that claim have it, they don't do it correctly. So you're correct. So we have that challenge. So that leaves us, well, what can we do? So the challenge with a structured, and the guidelines do give a higher recommendation for a structured program versus a non-structured program. And I think that anything is better than nothing. The challenge that I find is exactly what you said, is how many of our patients have the capabilities to even do the structured program themselves, because they don't have a treadmill. They don't have a membership in the gym. I mean, we're talking about patients that get PAD. We know that PAD is more prevalent in a more disadvantaged patients, people that come from a lower socioeconomic status, people that live in geographic areas that don't have the amenities for walking and outdoor activities. So with all of that, I don't want to just focus on the negatives, but there are a lot of challenges. But yes, so to answer your question, the structured exercise program is better than a non-structured program. We should definitely advocate for these and have our patients follow with this kind of a format of structured exercise. But understand that even that is going to be very limited. There are some, kind of a virtual telemedicine directed exercise and rehab programs that are coming out. As you know, there is many of them coming out. Even Amazon has a program now, I heard, and there are many other prominent organizations that are coming out with rehab, cardiac, and PAD And hopefully there are ways that we can encourage our patients remotely to be able to exercise, so we can elevate structural exercise programs by having a kind of a virtual oversight, so that we can guide our patients to do it in outdoor facilities or maybe at home if they can do it.
So when you're talking about structured, what are those parameters? Is it just that you have to have a start date and a finish date with someone looking at some data? Or are there a certain number of televisits that they need to do with a patient throughout, for the duration of those 3 months?
Yes.
What are the parameters around?
Yes. So we try to emulate, the supervised exercise program at home, basically, except that you're not going to a facility. You do not, somebody's not putting EKGs and monitors on you. Somebody is not monitoring you and taking information down. I mean, that's really supervised exercise, right? We follow the protocols about, the inclines and the speed and, all of that. So some of that is hard to do it in a structured program because patients may not have a treadmill. So the format is very similar to a supervised exercise program, but is less well defined, in a sense that there is not a formality to it. So that's point number one. Formality meaning that we don't have the monitors and you don't have somebody there to supervise you. But the bottom line is that we want to do this similar kind of a protocol, if you will, as we would do in an exercise program, with the duration and the period of time that the patients are doing this. Now, what is interesting is that if the virtual comes in, I think we can elevate that. And I think that's where the future hopefully can be a middle ground, where we have somebody virtually actually engaging with the patient to make sure that they are doing it. Because one of our challenges is that when we tell the patients to do it, they don't do it. Just like we tell them to take your cholesterol medication and they don't take it. And to be honest with you, it's hard for me to judge because I told you, I have a very strong family history of P.A.D. I mean, of coronary disease, not P.A.D., coronary disease. My dad died of heart attack. As I said, my brother had quadruple bypass at the age of 58. So I was told I need to take statins. It's not easy to take pills. I want to be honest with you. So I'm very, I've experienced this myself. So I have a lot of understanding of my patients, because my Lipitor is sitting right in front of my sink, at home, but I don't take it routinely. I forget. And it's very hard for me to judge my patients, because even though I know the circumstances, I know how important it is for me. I give lectures about how important it is to take your drugs. And I scream and yell to my patients, I forget myself. So while it's easy to tell our patients, please walk, they don't do it.
Yeah.
They don't do it. So I think that hopefully with the virtual structured programs, we can have a more of an effective approach to this, and we can get more of our patients to commit to walking.